I'm so excited to have you all joining us this afternoon. Our health equity webinars always produce really thoughtful and engaging conversations, and so I'm very grateful that everyone makes the time to come join us and to contribute to those conversations and to ask questions. I finally remembered to grab the questions that people submitted previously to the webinar for today, so we'll make sure that Delilah gets an opportunity to answer those as well. As per usual, I'm going to request that everyone keep their videos and their microphones off for the presentation. That way you can use the hide non-video participants feature, and that'll help to spotlight the speaker for you. We'll set aside 10 minutes at the end of the presentation so that you all have the opportunity to ask Delilah any questions that you might have. And so if any questions do come up during the presentation, you can use the chat function for that. My name is Natalia Mason. I'm the Community Engagement Specialist in the Division of Social Accountability. I'm joining you today from the College of Medicine's main campus, which is on Treaty 6 territory in Saskatoon. Treaty 6 territory is the homeland of the Métis Nation. Like many of you, my life has been enriched and sustained by the care and stewardship of these lands by Indigenous people. The DSA undertakes its work from an intersectional lens, which considers the relationship between power and varying forms of oppression. And I think for us in a Canadian context, it's really critical to be able to reflect on the historical and ongoing impacts of colonization on Indigenous people and their traditions and their communities. And that's something that I'm sure that Delilah will be touching on a little bit today as well. My dad immigrated to Canada from the Caribbean, and my mom is from a settler farming family. And so it's really important that I acknowledge that my family in coming to this place in pursuit of better opportunities has had a significant impact on the people who have traditionally called these territories home. And it's part of my role as a Canadian and in this job to be able to work to address that. So today's conversation is going to center around reproductive justice. And it's really important that we recognize that colonization was facilitated through and by perpetrating things like sexual violence, attacks on bodily autonomy, and has threatened traditional ways of understanding sexuality for people in this community. Really looking forward to unpacking some of that more with Delilah and having a fantastic conversation. For those of you who aren't familiar, the Division of Social Accountability is a division in the College of Medicine that's dedicated to health equity, anti-racist education, community-based research, advocacy, authentic partnerships, and the health needs of underserved and marginalized communities. We engage with and learn from our communities to support relevant, meaningful, and impactful health professional education, research, service, and advocacy. We offer our health equity webinar series to support student, faculty, and staff learning in the College of Medicine, touching on some of the priority health needs of those in the community. These webinars are always open invite, the more the merrier. And so if you enjoy your time today, I would encourage you to look out for our next webinar in June and to also spread the word to friends and colleagues. This month, I'm really excited to be welcoming Delilah Kamuhanda to our conversation. I've known Delilah for a number of years now. We've been really fortunate to work together, and I'm so excited for what they're going to offer today. Delilah is a Ugandan-American born and raised in the Piscataway Territory, which is now known as Maryland and Washington, D.C. They have a BA, a BA&Sc in health studies, and a minor in psychology from the University of Saskatchewan. Their experiences in and outside of academia led them to pursue a career in health education. She's worked on projects for environmental health and its impact on maternal and infant health, as well as the impacts of racism on health. Delilah is currently the Education and Outreach Coordinator at Saskatoon Sexual Health. Her approach to sexual health is sex positive, queer, inclusive, and anti-oppressive. When they're not talking about sex ed, they're an anti-racist educator, the founder of Black Lives Matter YXE, and a radio co-host. Delilah lives and works in Treaty 6 territory. And with that, Delilah, I'll turn it over to you.
Thank you. Hello, everyone. Share these slides. Okay. Oh, maybe you can't see anything. It always works the first time and then goes
We had
wrong.
your slides. You were good.
Oh, you could see them?
Yep.
Oh, okay. You can see them, right? Okay, cool. All right. Hello. My name is Delilah, like Natalia said, and I'm happy to be with you all today and talk about reproductive justice and the way that reproductive injustices manifest in our communities in the past and in the present, and how we move forward from those to more equitable futures and sustainable ways of caring for each other. Like Natalia very well, like Natalia talked about earlier, we are on Treaty 6 territory here in Saskatoon, and specifically what that means when we're talking about reproductive justice and maybe more accurately reproductive injustice, is that the lands we are on and the positions in power we hold on these lands, they're possible, unfortunately, through the legacies of colonization and, quite frankly, genocide that removed Indigenous peoples from these lands. And part of enacting those processes was reproductive manipulation, coercion, and removal of bodily autonomy. These legacies of colonization are intertwined with reproductive injustice and now reproductive health as we come to know it, understand it, and live it, especially for Indigenous communities. So we have to be aware of the harm sexual health has inflicted on Indigenous peoples, because we can't be trustworthy healthcare practitioners or educators without acknowledging why that distrust exists. And so it's important to also understand how this affects our pursuit of reconciliation as settlers. So what we'll be talking about today, what is reproductive justice, and sort of defining it and what it means from an intersectional framework perspective, sort of the histories of reproductive injustice and the current realities, what accessing abortion is like in Canada, what it means to pursue anti-racist sexual and reproductive health, and how we move forward in those ways. So what is reproductive justice? Well, it is a framework created by Black intersectional feminists like Loretta Ross, who has a book very aptly named Reproductive Justice. And it is first the right to have children, the right to not have children, and the right to raise your children in healthy environments. And Loretta Ross says, as Black women who understood abortion politics, right and left, we were always frustrated at how abortion was always isolated from all other social justice issues. We decided to take the concept of reproductive rights and splice it together with the concept of social justice, and we coined the term reproductive justice. So basically what she's talking about is that at the time, late 70s to early 90s, conversations about abortion were centered around white women's issues with access to abortion and the right to abortion. And I think there's a lot of parallels we can draw between what is happening at this time that she's describing and what is happening even currently with Indigenous people and coerced sterilization. It's that if you're more concerned that people don't believe that you have the right to have children, or you should even think about starting a family because of your race, your social economic status, your disability, then the right, or being pro-life or pro-choice, is not really a reflection of the real life issues that you're facing when it comes to reproductive health. So similarly, this group at a conference, they got together and they talked about how they want something that reflects more their lived experiences. People like Loretta Ross, who was actually forcibly sterilized in a procedure, They wanted something that reflected their lived experience. And at the time of the conference, Congress was working on healthcare reform, but reproductive was not part of the conversation. So they wanted it to not only be part of the conversation, but reflect a more diverse and inclusive take on this. So from what I've been talking about, maybe you've heard inclusive, diverse, intersectional a couple of times, and intersectionality was a main pillar of this framework. Intersectionality is a prism which we use to see the interactive effects of various forms of discrimination and disempowerment. And the term was coined by Kimberly Crenshaw of the Combahee Collective. So basically what that means is that if we look at any singular issue or singular marginalization, there are many ways in which those marginalizations can be impacted by either privileges or marginalizations. So we all hold power and we all maybe hold marginalized identities to some aspect. But when those things interact with each other or intersect with each other, they create a unique experience. So the experience of, a Black man who is cisgender and heterosexual is very different from my experience as a Black, queer, disabled, femme presenting person. So similarly, reproductive justice takes into account a few things that might affect people's access to reproductive health. And those things are geography, which I think in Saskatchewan we really get familiar with because we have such a large portion of our population living in rural settings, poverty, education, disability, access to information, inclusivity, income, and colonization. So what do these things mean when it comes to reproductive injustice? Obviously, some injustices occurred, which led to the creation of the term and the framework of reproductive justice. Well, if we look at just a brief overview of reproductive injustice, and obviously even this and the examples I'll go into a little bit further from the Canadian aspect don't even scratch the surface of what harms have been caused when it comes to healthcare, medical research, and policy. So if we look at it from kind of this broad overview, we can start with how enslavement often used reproductive health or fertile ability to determine the value of people for sale. And oftentimes when I talk about these types of things, people are like, oh, like, I don't think Canada had slavery. Canada did practice enslavement up until it was abolished by the British, because it was abolished by the British Empire for all colonies, including Canada, in August of 1834. And during that time, Canada did practice enslavement of both Black and Indigenous peoples. There is the infamous story of an enslaved woman named Lydia Jackson, who was free and then tricked into indentured servitude and then sold by the person who had tricked her into indentured servitude back into enslavement. And the physician who enslaved her and his wife were very, very violent. They would do unspeakable things, and to the point where when she was 7 to 8 months pregnant, they physically assaulted her until she miscarried. And when she sued for false imprisonment and false enslavement and physical assault, she was basically laughed off from even filing a suit, because not only was he a physician, but she was a Black person who no one would believe, basically. And this is in Nova Scotia in 1790. Then we have J. Marion Sims, infamous physician, although I will say that like some of the critiques really need to put what he has done in the context of the day doesn't mean that anything he done is less horrible or that we should now praise him because other people were doing not so great things, but there was really a culture of experimentation on enslaved people at the time, which he fed into. And if we look at who was enslaving people at the time in Canada, we also see lots of hospitals, physicians, researchers enslaving people, and possibly the same legacies existing here, except we kind of lack the research in that way. But J. Marion Sims was once considered the father of gynecology for his work on enslaved people and the surgeries that he did on them without anesthesia. Then it goes into issues of would anesthesia be the proper treatment because of all these different things. Really recommend Dorothy Roberts' book on killing the Black body. She really goes into detail about like what he was doing and what was actually standard, what was maybe helpful, and what was really just abusive and experimental and cruel. And so he would often either kind of borrow enslaved people or buy enslaved people for the purposes of experimentation and exploratory surgeries. And yes, very, very cruel, very, very dark history when it comes to that. Then we have the early 1900s ban on Black midwives. So during this time, as gynecology is becoming a sort of more formalized practice, Black midwives served everybody in the community, white, Black, Indigenous people, people of all races, social economic status could depend on these people in the community. There was even one story about how George Washington's midwife on his plantation was given, she was given freedom. She had her own like home on the plantation in the area so that she could do her work. So they carried a lot of power because in bringing enslaved people into this world, you are creating income for somebody, unfortunately, as were the times. And people entering the field of gynecology did not like the challenge that provided to them. And so soon after, more gynecologists start to arise and formalize their practice and communicate with each other, this ban on Black midwives came about, and they partnered with nurses and policymakers to basically create a smear campaign and call Black midwives unhygienic, barbaric, unexperienced, a lot of racist rhetoric as well. Then we have the Tuskegee syphilis study, which was basically founded on the idea that at the time they believed, because of eugenics, racist science, that Black people were mentally and intellectually inferior, and thus if syphilis long-term affects the brain and neural biology, then it should by their logic affect Black people's brains differently and Black people's bodies differently. And so common misconception is that they infected people with syphilis. That is not true, although there was another study in a US territory where that did happen. So, but that's outside of this particular study. They found people that had syphilis in the community. They didn't tell them about their status or how syphilis spread, and so it was able to proliferate in the community, infect partners, infect children, and create a lot of negative health impacts in the community. And people are basically forced into staying in the study. Many wars happened in this time period. They were not allowed to join public service. They were not allowed to join the army because entering the army would mean that you were getting tested, which means that when penicillin was available, you were getting treated. So they did everything in their power to keep people in this study and to also keep them away from treatment. And at this point, before penicillin was created, most people that had syphilis had long-term syphilis. So we didn't really need to study the impacts of long-term syphilis. What they wanted to do was further racist science with this study. Then we have the Puerto Rican birth control trials, and during this time, people were still trying to decipher, like, what does birth control do? What are some side effects? And they preyed upon poor and not very well educated, or not, as bilingual when it comes to English, Puerto Rican people to join this study. And some of the people in the first trials died. And so a lot of people did not want to join the studies anymore. And so when people would not join the study, or the local women in the community band together to sort of ban others from joining the study or the trial, they turned to people that they could force into the trials. And that meant medical students who they could threaten with not being able to graduate or practice, and people that were institutionalized in basically mental health facilities. And then from the early to mid 1900s, there was also a mass imprisonment of people believed to be sexually immoral or with STIs. So this not only included people that were part of the Two-Spirit LGBTQIA+ community, but if you were believed to have any sort of STI, and what it would basically allow officers and health professionals to do is very inappropriate, abusive, and traumatic gynecological exams. And I'm not even comfortable using exams because there was really no scientific or healthcare purpose for this. They were mostly just abusing people who they thought were harlots, or the term of the time. There we go. Okay, so these are kind of a brief overview of things that mostly happen around the world, some in Canada, some in the US. What are things that are specific to Canada? Well, we have the Canadian eugenics movements in the early 20th century, and now hopefully we all know that eugenics is outdated, but at the time it was seen as a progressive and, science movement, this newfangled thing of science and biology. It was all the rage, and it was seen as really progressive even when it wasn't. And a lot of people that practice eugenics assume that Canadian society would be improved by reproduction among certain groups. Not coincidentally, those certain groups were white settlers, specifically Anglo-Saxon Protestants. And the other side of that was to discourage or limit reproduction among other groups. And those other groups included Eastern Europeans, immigrants, and Indigenous people. And often when I talk about how eugenics is racist, some people will wonder, like, well, then why are Eastern Europeans included in that group of people that are undesirable to reproduce? At the time, whiteness was a very specific type of whiteness, and there's a lot of research and great resources out there, some by Dr. Sheila McLean, who is from Saskatchewan, about how whiteness has developed over time. So at that time, people that were Ukrainian, Eastern European, Greek, Italian, they were not part of what whiteness meant at that time. Over time, that has changed, and how we define or understand whiteness continues to change. So for example, we can see how there are similarities between the way that people would talk about Irish Canadians or Irish Americans versus British or white Canadians. And so these are terms that change over time. But from the eugenics movement came the Sexual Sterilization Act in Alberta from 1928 to 1972. We'll get into what that meant in terms of actual effects on people, especially Indigenous people in Alberta. But then and now, these beliefs around eugenics have led to sterilization of disabled people, imprisoned people, Black, Indigenous people of color, and the legacy of eugenics has seen its way into sexual health education and how it's taught today, and even how we go about recommending reproductive health care to people. So for example, if people come in and maybe their care provider, their parents, their physician, nurse thinks because they are disabled or possibly because they are a lower economic status or because they are racialized, that, oh, we really need to recommend something that is a LARC, so a long-acting reproductive contraceptive to this person. So we'll often see how even maybe if someone doesn't understand what something is or what a medication is doing, reproductive or LARCs, long-acting reproductive contraceptives, might be recommended to them or pushed upon them because of these ideals of who should be reproducing and who we should really have a vested interest in not reproducing. Okay, so what does eugenics mean for anti-Indigenous racism within reproductive healthcare? Well, unfortunately, a lot. So under Alberta's Sexual Sterilization Act at the beginning, so when it started in the late 1920s, it really targeted a lot of disabled people and institutionalized people. And then as time went on, Indigenous people became a large target for this, and sterilization was a common practice in a lot of Indian hospitals. So although Indigenous people represented only 3% of the population, they represented about 25% of those sterilized under this act until its end in the 70s. Indigenous communities also began to demand healthcare in their communities, especially to address the high rates of maternal mortality. And the government thought the cost to develop healthcare facilities in the North would be too expensive. So instead, they opted to provide them with what was at the time illegal contraceptives. And this was a means to prevent pregnancy and thus maternal mortality, a very roundabout way to prevent that, but also to control the Indigenous population of the time. And using of the time very liberally, because again, you can see how those examples that I was just talking about affect modern day prescriptions for LARCs. Some people were given experimental Depo-Provera shots and LARCs before they were even approved in Canada. And with that, we can also see how now today, talking about access to reproductive health care, which, I mean, we want to increase access, but there are certain people who do have access because society sees them as unfit to be parents or unfit to reproduce. And so we've been pushing these things upon them. And then also not giving fair access to people that maybe actually do want them. There was also a similar ban of Indigenous midwives. So midwifery was a part of Indigenous communities and often a cornerstone of their communities for years and centuries pre-colonially. It was only in the last 100 years that the practice was taken away from Indigenous communities. Under the Indian Act, Indigenous people weren't allowed to partake in their cultural practices and ceremonies. They were outlawed, banned, restricted, and had to often be hidden or just not occur. Without adequate traditional or Western healthcare, pregnancy and childbirth became very dangerous in these communities. And with the lack of healthcare funding and facilities, like we just talked about, Indigenous folks often had to leave their communities for delivery. And then Health Canada's evacuation policy requires Indigenous people on rural or remote reserves to evacuate their communities at 36 to 38 weeks of pregnancy. So now sometimes you'll see a headline like the first baby born in said community in over 50, 60 years or something like that is the headline. And that's because care was restricted through the Indian Act and then not adequately provided through government and systemic neglect. And then, people were forcibly or had to leave their communities. And in the last few decades, Indigenous knowledge keepers and healthcare providers have been working to restore these practices, and we'll talk about that a little later. Some recent things that are happening, which I'm sure maybe we've heard of, it's the sterilization of Indigenous people in Saskatchewan, particularly the 2015 reports that surfaced indicating that Indigenous women were coerced into having tubal ligations at RUH and in Saskatchewan. We then have the 2021 reports where Indigenous and Black, mostly immigrant and Haitian people in Quebec were also being coerced into sterilization. Oftentimes, part of this coercion would be that, you might get your children taken away, or you might not be able to see your children, or they might be apprehended, or just, coercing people into these procedures while they are not coherent enough to make that decision with adequate consent. And then we have the end of Roe v. Wade in the US and that overturning decision, which doesn't affect us here in Canada, but it has sparked more debate, interest, and conversation around abortion rights, and access. And that increase in stigma can also affect how people view abortion and how they access it. So why do we have to drudge through all the history? Partially because I'm a history nerd, so I want everyone to know these things, but also because I strongly believe in the Sankofa adage of the Adinkra symbols. It's like kind of like an African principle now in Pan-Africanism, that in order to move forward in a knowledgeable and good way, you have to be deeply planted and deeply rooted. And to do that, you have to learn from the past and take from your history in order to move forward in a good way. And so I think it's really important that we understand that people's distrust in healthcare doesn't just come out of nowhere. These fears and this apprehension is based on decades and even centuries of mistreatment, experimentation, disrespect, racism, marginalization, coercion that have led to these feelings of distrust and disbelief in traditional healthcare settings, traditional Western healthcare settings. And these examples are just a few of the very well-known ones. And it's not just, people's, small feelings. These are trauma and violence, really, that inflicted people of color, disabled people, and other marginalized communities. And these communities, they still demonstrate incredible resilience and desire to overcome. Like I mentioned, there's a lot of knowledge keepers and Indigenous midwives working on reconnecting to these practices in Indigenous midwife ceremony. So the distrust in healthcare systems and healthcare providers, coupled with the continuation of racist policies and beliefs, leads to infrequent and reduced use of healthcare services, poor health outcomes, and mistreatment in healthcare settings. So we can see how these things are intertwined with each other, but also the history that grounds them in this feeling of distrust. So what does the impact of this history mean for our lived realities? Some of the statistics around these show that there are large gaps in who we see contracting HIV at this time. And if we look at Saskatchewan with our 3 times national average rate of HIV, and even higher in the city of Saskatoon, then we know that there are some distinct issues with how we are addressing HIV, and it needs to be culturally appropriate and respectful. Unfortunately, we don't have a lot of statistics when it comes to PrEP use in Canada, but what we do know is that PrEP users, so PrEP is prophylactic medication to prevent HIV, PrEP users tend to be white, older, queer men or MSM, masculine folks who have sex with other masculine folks. And if we see that there's already a racial gap in who has HIV, and we see that there's a huge gap in who is accessing a vital prevention medication for HIV, then we know that, or what is being estimated is that that gap is going to increase in the next few years as we see more PrEP users or more people get access to PrEP. And if more people of color don't get access to PrEP, then we can see how that issue sort of proliferates. We also see that there are still a lot of myths rooted in that history of eugenics and racial science, that Black people don't experience pain or they experience less pain, which we can also connect to the experiments of J. Marion Sims and also the current issues with Black maternal health outcomes. It's also really connected with this idea that because Black skin has more melanin, and so maybe you can't see veins as easily as you would on lighter patients, that they experience, or that their skin is thicker, which also leads to experiencing less pain, thing that I just talked about. So a study in 2016 found that 40% of surveyed first and second year medical students believe that Black skin is thicker than white skin. And I can't tell you how many times I go to get like blood work done and I have to stop the person right there and be like, no, it's not, let's not. Okay, then we have sort of who is getting tested, who is accessing sexual health care. Among street-involved youth in Canada, we see that youth of color are less likely to have access to STBBI testing. Similarly, we also see that cervical cancer screening in the US is less frequented by Black women, so they're less likely to get early diagnoses when it comes to cervical cancer and things like that. We also see that many Black, African, and Caribbean youth state that racism is a key barrier to accessing sexual health services. And from the Toronto Teen Survey, we see that this is the population that's also the least likely to report having attended or visited a sexual health clinic. And then, like I said, in Saskatchewan, we're seeing that some reserved communities have high transmission rates of HIV. Some of these are about 10 times the national average. So, abortion access in Canada. Like I said, everything we see around reproductive health and reproductive justice is really related to intersectional frameworks. And so abortion is legal in Canada, fortunately, but that doesn't always mean that it is accessible. So let's talk about abortion policy and how it sort of changed over time. In 1969, contraceptives were decriminalized, like I talked about earlier. There were some people that were able to access contraceptives and sterilization because of ableism and racism. We also see in that year that the first abortion clinic starts in Montreal. In 82, there's the Charter of Rights and Freedoms. In 88, the Supreme Court of Canada strikes down Canada's abortion law as unconstitutional, so really formalizing the existence or the legal existence of abortion care. But then shortly after, in 1992, Dr. Morgenthaler's Toronto clinic is firebombed. And that is a continuation of some anti-abortion violence. So in 94, we see that the first Canadian doctor is shot for performing abortions, and two similar shootings follow in 95 and 97. In 2008, Dr. Morgenthaler receives the Order of Canada in 2015 after one of the lengthiest drug approval processes on record. Health Canada approved the abortion pill mifepristone. And in 2021, bubble policies are introduced on a federal level and also at a provincial level in Saskatchewan, although the provincial level one has not been approved. Okay, so what happens when people find out that they are pregnant and how do they access abortion? 50% of all pregnancies are unplanned and 50% of unplanned pregnancies end in abortion. It is a normal and essential part of healthcare, and it is very common. Unsafe abortion still occurs, and it accounts for about 13% of birthing mortality worldwide. If you follow Saskatoon Sexual Health on social media, you might have seen our sort of series on people's experience with abortion access. And there are people that were in rural communities that talked about doing unsafe and self-managed abortions because they feared the stigma and all of the barriers to accessing abortion from a traditional healthcare setting. And it's estimated that about 1 in 3 Canadians with a uterus will have an abortion in their lifetime. So how do people access abortions in our province? Unfortunately, access to abortion in Saskatchewan is unreliable because I think it's about only 1 in 6 hospitals nationally, so Canada-wide, offer abortion services. And most of them are concentrated to urban settings. Nonprofits like SSH help to fill the gaps with referrals and also like the community clinics and some gynecology OB-GYN offices help to kind of bridge this gap. Sometimes women that have an ultrasound have to see a physician for consultation prior to the procedure. And procedures are all done at the Women's Health Center at City Hospital in Saskatoon when it comes to abortion access. And abortions are only done up to 12 weeks in Saskatoon, although I'm hearing that that is something that is changing a little bit to sort of match Regina and is kind of a holdover from when the health regions were separate. And in Regina, it's about 18 weeks. Otherwise, people have to travel to other provinces. So 20 weeks is the limit in Alberta and up to 23 weeks and 6 days in BC. Otherwise, they have to leave the country. And that is something that will also be affected by Roe v. Wade, is how far will they have to travel and what's accessible to them if they do have to travel out of the country for these services. Some of the barriers to abortion access in Canada are distance, travel expenses, childcare, having to do multiple appointments. So appointment to discuss the abortion, appointment to do the ultrasound, appointment for blood work, appointment to get the medication or do the procedure, and then a follow-up to make sure that the medication worked or that everything went well with the procedure. Could be that there's certain times for appointments at the hospital. They could find that they go to an anti-choice healthcare practitioner that doesn't give them a referral, or maybe dissuades them for accessing abortion, or maybe refers them to a CPC, which is basically a fake clinic that sort of appears to be an abortion clinic, but that sort of lures people in and then dissuades them. They sometimes offer things that can be helpful, like formula, like adoption services, but it's more about getting people in and dissuading them from getting abortions. And Misinformed, that's what it is. Misinformed Canada has a lot of information about those facilities. It could be a lack of information, so not knowing what their options are, and also the time limits, like we said, the 12 weeks, 18 weeks, 20 weeks, 23 weeks. So the inequities that we talked about in reproductive health also apply to abortion access. So when we look at rural versus urban, we see that more people in Saskatchewan especially have to travel long distances to access abortion care. So I think it's 18% of women have to travel over 100 kilometers. And when it comes to Indigenous communities, Indigenous people are 3 times more likely to have to travel over 100 kilometers to access an abortion. Then we see that vulnerable folks accessing abortion also struggle because of cost, because of status. So people experiencing homelessness or with precarious immigration status are less likely to have active health cards. And that means they might have to pay for appointments out of pocket. And that means medication, appointments, tests, etc. And also trans folks on hormone replacement therapy. HRT and testosterone is not an adequate form of contraceptive. It can reduce your likelihood of getting pregnant, sometimes, extremely, but it's not an adequate form of birth control. And there's a lot of misinformation about it. So especially if someone has just started HRT, they might experience irregular periods or inconsistent periods, and therefore it may make it harder for them to discover that they are pregnant. And then also, traversing a pregnancy and abortion services that are, very gendered can also be a triggering experience for them as well, which also might delay them seeking out those services. And then the cost. So most people that get abortions, I think it's somewhere like about half of people that get abortions are already parents. And so the cost of childcare really comes into play. And if they can find someone, especially if they have to travel long distances, then, travel alone, taking time off of work, if they need to get a hotel, all these other things can affect the cost. They can sometimes apply depending on the person and the province. They can apply to get reimbursed, but you then have to have those costs upfront available to you. So how do we move towards equity and justice in reproductive health care? So where can we start? We just talked about a lot of history, a lot of systemic things. It's important to remember that after this, I don't expect anyone to go and really take down these giant, centuries old harmful practices and institutions. That would be great, but it would also be fairly impossible. But it's kind of about those knowledge shifts that lead to habit shifts that lead to system shifts. So taking it sort of step by step, day by day. Reproductive health is deeply impacted by accessibility and inclusivity. And those are things that we can start on as individuals or as groups in our own communities, because again, we also know our roles best. I saw, some friends here who are educators. I saw some people I know are physicians, some people I know who are in academia. So we all know what roles we play and how we can take one of these pieces and introduce it to what we do or what, our workplaces do or our communities do. So some things that we can ask ourselves are the resources, tools, and models we use diverse? So for example, at SSH, sometimes I teach with genital models, and we use Sex Ed Plus for our resources, and they have diverse models, and they have trans and gender diverse models as well. And we try to use varying skin tones and things like that. Are your services or resources available to people with varying levels of education, meaning that they're easy to read at different reading levels? They're accessible to people with reduced mobility, and people from rural communities or parents can access these services or resources. Are BIPOC leaders, employees, community members meaningfully engaged? So not just in the room, but made to feel uncomfortable and silenced, but meaningfully engaged, which is very different. And also, if it's not their job, if they are not the DEI specialist, that's diversity, equity, and inclusion, they don't have to be a part of these efforts. Are they given the space to say no? Are they given the space to say, this is not my job, this is outside my capacity? How will feedback be addressed about these issues? So for example, we had feedback that on our intake form that asking people what their ethnicity was could be a barrier for Indigenous people who, again, have a history of being coerced into LARCs and sterilization. And so to even just saying like, would you like to self-identify, could feel like if they do self-identify that they won't get the care that everybody else will get. So then we just took that out of our intake form because we didn't really need to collect that information anymore. It was something that was just a holdover from a grant that asked, to make sure that we're serving a diverse population, and we feel like we serve a diverse population and we don't want to harm anyone, so we just removed it. And also thinking about how anti-racism, diversity, inclusion, equity, and justice can be integrated into your strategic planning, your mission, your vision, your curriculum. So one thing that looks like is the Native Midwives Association. They are looking to revitalize cultural practices around childbirth. There are some knowledge keepers that are trying to reconnect to ceremonies regarding coming of age, so like noontime and puberty. So they're like ceremonies. I'm speaking from a settler perspective. Please go and find, I have the resource at the end so you can find out more about these specific practices, but it's kind of a time to not only educate about puberty and coming of age, but understand the change in your responsibility and connect with the people in your community, which is very different from the sort of stigmatized view people have around menstruation in our society today. All right, so our top tips and takeaways are to amplify marginalized voices, diversify your sources and team, prioritize cultural safety, meaning that we're not forcing anyone, especially marginalized people, to do this work. And we're also prioritizing that they feel comfortable, heard, and safe when these conversations are happening. We are acknowledging and understanding privilege, like we talked about with intersectionality. We understand how to integrate reconciliation work. So really paying attention, especially in a Canadian and Saskatchewan context, to the ways that racism deeply affects Indigenous people in the community and how it's really stripped them of being able to connect to ceremony, parenting, reproductive health, and healthcare in general. To share and hold space. So holding space for people whose understanding and perspective is, different from your own. Incorporating discussions of race, I'll change it to racism because we don't want to say this group has this increased risk of that without mentioning that it's not because the group inherently has something wrong with them. It's because of the structures of systemic racism that have impacted their health outcomes. Familiarizing ourselves with intersectionality, we can check that off. We did that today. Understanding barriers to newcomers and maintaining a growth mindset. Natalia and I started doing an anti-racism sexual health education resource maybe 2 years ago now, a year ago now. And since then, how we talk about this has changed. I've learned more. I found more books, unfortunately. The list is long of resources and additional sources, but you can always learn more. All right, that's everything. And this is a photo from Abire Illustrates. I think I have that as one of the links in the additional resources I'll put in the chat. And he makes these diverse medical drawings. And so this is the first time that this group of Maasai women have seen a pregnancy and fetus model that reflects their own skin tone. So yeah, it's a way that the things that we're doing and changing today are really having an impact in, real communities. All right, that is everything. Thanks, everyone.
Thank you so much, Delilah. Before I forget, I'll invite everyone, if you can, to turn your cameras on so that Delilah can see that she's got a rapt audience who very much enjoyed all of the information that you had to share. We got about 5 minutes here, so I'll see if anybody in the audience has any questions that they'd like to ask first. Okay, well, I've got a couple that were from before the presentation. So I will ask one of those. So one of the questions actually says, your bio says that your approach to sexual health is sex positive. What does that mean?
Yeah, so what that means is that when I'm talking about sexual health or sexual health education, I don't approach it from like a negative or shameful perspective. Unfortunately, there's a lot of stigma and um, shame and um, taboo associated with sexual health and sexuality, and that can be really intertwined with how people discuss these things. And sex positivity is more about treating sex like a thing that a lot of people do, and if people don't, that's okay. That's, you know, that's everyone's choice. So understanding that people can be asexual and people can also be sexual beings, all of those things are okay, and that we're not here to judge, we're here to provide the tools and resources people need to live healthier lives.
Brilliant, thanks. There is another question that says, how do you compare the racism experienced by African Canadians versus that experienced by First Nations, Métis, and Inuit people in Canada?
I feel like that's a hard question because, again, I'm not Indigenous, so I can't be like, well, I've lived like this and then I lived like that, and now I can compare the two, you know. But I think that something that Dr. Holly Graham mentioned the other week at a training was that Indigenous people have a unique relationship with the government of Canada. And it's a very complicated relationship and abusive relationship. And although Black people in Canada have experienced racism and experienced systemic and institutionalized racism, we don't have that relationship. So there's a great Afro-Indigenous educator, Amber Smoke, and she talks about how in the US, like there's an experience of Indigenous people being invisibilized, so made to seem invisible, because if people are invisible, then we can take their land because they don't exist. And then racism towards Black people is about being hyper visible. It's much more apparent that they're the other, and therefore we treat them as the other, and we treat them being around like it is a bad thing. She was doing a seminar and I asked her, like, what would you say that dynamic is the same in Canada? And she said that she would say that dynamic is almost flipped in Canada, because of the history of anti-Indigenous racism and that relationship with the government really impacting how people see and the visibility of Indigenous people. So I more lean to her description because she is Afro-Indigenous.
Yeah, that's brilliant, honestly, really well put. I appreciate that. We've only got a minute here. So again, Delilah, I just want to offer you the most sincere thanks. Everyone was dropping thank yous and congratulating you for the presentation in the chat there. We really appreciate it. As always, I'll share our link tree for the DSA. Stay in touch. We've got lots on the go. Things will be Pride themed next month. We'll still be offering a webinar. We've got our book club coming up next week. So for those of you who are in the College of Medicine, if you'd like to join us for that, I believe it's on June 1st and the 7th. And info about book club, info about webinar, all of those things can be found in that link tree there. Thank you all for joining us. And I'll make sure that I send out the resources when we send out the recording and the survey for today's presentation. So if you enjoyed it, do make sure that you fill that out. Bye, everybody. Thanks, Delilah.
Thank you.